Yes, good evening, sir. We can hear your voice.
Uh, uh, Warm welcome to everyone and very good evening. Today, what we are going to discuss is not really written well in the books. It is purely based on the experience of the consultant, based on which the lecture has been prepared by me. And what we are going to understand and learn will help us a lot when we are doing echo, especially in NICU. So let us start our journey on approach to neonate with pulmonary hypertension with echocardiography perspective. We'll start with a case scenario where we have 1 day old baby. He presents to us in fetal distress and for which cesarean section was done. There was cord around the neck and the child did not cry. The child was received in NICU on mechanical ventilation. On examination, the peripheries were warm, heart rate was 176, blood pressure was okay, 66/32, all pulses are palpable. There is hepatomegaly, hyperdynamic precordium. Hyperdynamic precordium is suggested by when you put the hand on the chest, you experience the fast beating heart. That is the hyperdynamic precordium, and a soft systolic murmur. Chest X-ray showed cardiomegaly with hazy lung fields, and ABG showed metabolic acidosis, pH 7.2, PCO2 40, PO2 40, PCO2 32, and saturation was 78. CBC was normal. So echo was done. Echo showed right heart dilatation with tricuspid regurgitation mild, and the velocity of 66 millimeters of mercury in systole. Patent foramen ovale was there, and PDA is also there. Both are shunting bidirectional, which means that the child is having pulmonary hypertension and the ventricular function was not well. So this is the echo. The emphasis is when you see the 4-chamber view, you can clearly feel that the right side of the heart is dilated. The right atrium and the right ventricle are more dilated than the left atrium and the left ventricle. You have a tricuspid regurgitation jet. And what we can see over here is the subcostal view, wherein the right-sided chamber is the right atrium and the left-sided chamber is the left atrium. And we can see that the blood is moving in this direction, which means that the PFO is shunting right to left. When you see the PFO is shunting right to left, it means that the pressures on the right side are more than the pressures on the left side. So what is the physiology that we are dealing with? So we are dealing with a neonate who is having pulmonary hypertension, metabolic acidosis, and all this is because of perinatal hypoxia. So we need to stabilize the child. We started him on oxygen. Because there was ventricular dysfunction, inotropes was started. High frequency ventilation was also started. Severe metabolic acidosis, low cardiac output, milrinone was started. Various other drugs, sildenafil, nitric oxide, these all things were given, and henceforth there is a long list of drugs which is to be given in pulmonary hypertension patient. So let us learn what is pulmonary hypertension. Pulmonary hypertension is defined as mean blood pressure, mean pulmonary arterial pressure of more than 25 millimeters of mercury at rest or more than 30 millimeters of mercury on exercise. So on what factors does the blood pressure depend? The blood pressure is a measure of cardiac output plus vascular resistance. So for a systemic blood pressure, the left ventricle output plus multiplied by the systemic vascular resistance will give you the systemic blood pressure, and the right ventricular cardiac output plus pulmonary vascular resistance will give you the pulmonary blood pressure. So on what factors does the pulmonary blood pressure depends? The pulmonary blood pressure depends on these two factors. If pulmonary vascular resistance increases, the pulmonary blood pressure will increase. If cardiac output or the pulmonary blood flow will increase, the blood pressure will increase. So because of either of the two factors, you will have rise in blood pressure. You can have pulmonary hypertension. So what are the normal values of the blood pressure? So for the aortic blood pressure, when the child is born, the blood pressure is 60/40. And when the child grows to the adulthood, it reaches to 120/80. But if you consider about the pulmonary pressure, at birth, the pulmonary pressure is 25/10. And as the child becomes adult, it continues to be same. It does not increases with time. It is only the systemic blood pressure which increases with time, but the pulmonary blood pressure continues to stay constant even if the child grows right from day one of life. So what is fetal circulation? To understand the pulmonary hypertension physiology in a neonate, we need to understand the basics of fetal circulation. So you have a baby, and the baby is supplied from the mother through the placenta. So placenta is connected to the baby with the help of umbilical cord, and this umbilical cord has three vessels, one umbilical vein and two umbilical artery. Normally, the umbilical artery carries an oxygenated blood and the vein carries a deoxygenated blood. But in this scenario, because the vein goes into the baby and it contains oxygenated blood, so this is demarcated by red. One vessel or the single umbilical vein is red, means it is carrying an oxygenated blood. And the blood, after being utilized by the fetus, it reaches back to the umbilical cord through two umbilical arteries. So we can see two umbilical arteries reaching back to the umbilical cord. So the umbilical artery carries deoxygenated blood back from the baby, and the umbilical vein moves the blood from the placenta, from the mother to the baby, where it opens into the inferior vena cava with a small constriction, and that constriction is a ductus venosus. Ductus venosus will prevent the free flow of blood to the baby. By this constriction, it will prevent the pooling of blood into the baby's heart. So how does fetal circulation work? So this is now the umbilical vein. Umbilical vein is opening into the inferior vena cava, and these oxygenated blood from the inferior vena cava, there is a Eustachian valve that we have discussed in the previous lecture. This Eustachian valve will divert the blood into the left atrium through the foramen ovum. And these oxygenated blood will directly go into the left atrium, and from left atrium, the blood goes into the left ventricle. And from left ventricle, this blood will go to the brain to supply the brain. The brain is the vitalmost organ and receives the oxygenated blood. After the brain receives the oxygenated blood, it gets drained. It comes to the inferior vena cava, and from brain, the deoxygenated blood comes to the inferior vena cava, and this deoxygenated blood comes into the right atrium, the right ventricle, and coming to the right ventricle, what happens? Whether it goes to the lungs? No. The pulmonary vascular resistance of the lung is very, very high before birth. That is when in the fetal life. So only 10% of the blood will go into the lungs, and the majority of the 90% of the blood which comes into the right ventricle will go via the PDA or the ductus arteriosus to the lower limb and hence supply the rest of the body. From there, it goes into the pulmonary vein, pulmonary artery, and then goes into the umbilical cord. So this is how the fetal circulation happens. So only 10% of the blood goes into the lungs because the pulmonary vascular resistance is very, very high. So now what will happen when the child will born? When the child will born, two incidents happens. The child will have first breath. The child will cry. The child will cry, will have first breath, and as soon as the child has first breath, the lungs will open up and the pulmonary vascular resistance will fall. And on the other side, you clamp the umbilical cord. So by clamping the umbilical cord, what happens that the pressure in the umbilical vein will rise and the umbilical artery will rise, and hence the systemic vascular resistance of the baby will increase. So the pressure in the aorta will increase. So there will be decrease in the pressure on this side and increase in the pressure on this side. So what will happen? Because of increase in the pressure on this left side, the left ventricular pressure will rise, the left atrial pressure will rise. So the blood which was coming from the IVC via foramen oval to the left atrium will not happen. This foramen oval will close because the left atrial pressure is now more. And the blood coming from the IVC will now go down into the right ventricle. The blood will which comes into the right ventricle. Now, because the lungs are opened up and the pulmonary vascular resistance is fallen down, the blood will go into the lungs and the ductus arteriosus or the patent ductus arteriosus will carry oxygenated blood, which will cause constriction of the ductus arteriosus, and the ductus arteriosus will close in 24 to 48 hours. So this is how the transition happens from fetal circulation to postnatal circulation, where after the child is born, the pulmonary vascular resistance will fall, the systemic vascular resistance will increase, and hence the flow right to left shunting across the foramen oval and right to left shunting across the ductus will not happen, and the ductus arteriosus will close and the foramen oval will also close. But if this transition is not smooth, if something abnormal happens, then what is going to happen? So if there is any insult, like the child is having lung pathology, if there is an episode of perinatal hypoxia, or like cord around the neck, that what you have seen in the first example, or there is some congenital heart disease, all these three factors will not allow the pulmonary vascular resistance to fall. Though after clamping of the cord, the systemic vascular resistance will rise, the pulmonary vascular resistance continues to be high, and hence there will be continuity of right to left shunting across the ductus arteriosus as well as the foramen oval. What we have seen on the echo, the right to left shunting across the foramen oval, is a normal phenomenon in the fetus. If you do fetal echocardiography, right to left shunting across the foramen oval is a normal phenomenon. But if the right to left shunting across the foramen oval and the ductus arteriosus persist even after the birth, it is known as persistence of fetal circulation, which is due to non-regression of pulmonary vascular resistance. So pulmonary vascular resistance is high, what we call in a different word as persistent pulmonary hypertension of newborn. So how will you estimate PA pressures on echo after the child is born? So there are three ways to calculate the pulmonary artery pressure. One is the right ventricular pressure measurement. One is the pulmonary regurgitation jet. And the other method is through the gradient across the PDA and if there is any associated cardiac disease like VSD. So by these three jet velocity measurement, you will be able to measure the PA pressures. So let us start with the understanding how are you going to measure the PA pressures with these three jets. So now the right ventricle is in communication with the pulmonary artery. Now during systole, the pulmonary valve is open. So when the right ventricle contracts in systole, the blood from the right ventricle will go into the pulmonary artery, and hence the pressure in the right ventricle and the pulmonary artery will be same during systole. So when you measure the tricuspid regurgitation jet, which actually measures the pressure difference between the right ventricle and the right atrium, will give you the measurement of the right ventricle, and hence you get the right ventricle pressure. That right ventricular pressure will be equal to the pulmonary artery pressure if there is no obstruction at pulmonary valve level. Similarly, for a pulmonary regurgitation jet, pulmonary regurgitation occurs during diastole. So during diastole, when you measure the jet velocity, it will give you pressure difference between the right ventricle and the pulmonary artery. So during diastole, when you measure the pressure difference between these two chambers, the right ventricle and the pulmonary artery, it will give you the pulmonary artery diastolic pressure. So let us see how it happens. The right ventricular systolic pressure is equal to pulmonary artery systolic pressure when there is no right ventricular outflow tract obstruction that we have seen on the picture. So the velocity of the tricuspid regurgitation jet is basically the difference between the pressure difference between the right ventricle and the right atrium. So as per the Bernoulli's equation, the tricuspid regurgitation jet velocity is 4 into velocity square plus right atrial pressure will give you right ventricular systolic pressure. So when you have a normal RA pressure, we consider it as 5. But when you have right heart dilatation or in adult, we measure the inferior vena cava or the CVP, and that CVP is considered as equal to the RA pressure, and you add that RA pressure to the tricuspid regurgitation jet, and that will give you the right ventricular systolic pressure, or in other words, the pulmonary artery systolic pressure. So you focus the 4-chamber view, the tricuspid regurgitation jet, put your cursor on the regurgitation jet and press continuous wave Doppler. So when you have the 4-chamber view, you get the tricuspid regurgitation jet, put the cursor and press continuous wave Doppler. By doing so, you will get a tongue-shaped tricuspid regurgitation continuous wave velocity jet. What we can see over here is the waves are not very clear. So by aligning the cursor well, we were able to get a better wave pattern, and the velocity also increased. What we are seeing, the velocity is 4 meters per second. From Bernoulli's equation, you can convert it into pressure gradient also. The velocity is equal to the pressure is equal to 4 into velocity square will give you. So 4 into 4 square, that is 16.9. It will give you around 64, but it is 0.09. So it is coming around 67.07. So you can measure it on calculator also. It will come the same thing, but the machine nowadays give us the velocity in terms of pressure in millimeters of mercury. So from pulmonary, in case of pulmonary regurgitation jet, pulmonary regurgitation diastolic event, and hence the pressure difference between the right ventricle and the PA pressure during diastole will give you two types of pressure, that is the PA and diastolic pressure. That is what we measure in terms like 25 by 10. So 10 is the PA and diastolic pressure. 25 is PA systolic pressure, and mean of 15. So like 15 is a PA mean pressure. So how are you going to calculate PA and diastolic pressure and PA mean pressure? PA and diastolic pressure is the PR jet velocity at the end of the jet plus RA pressure, and the PA mean pressure is the PR jet at the beginning. When you take the PR jet continuous wave Doppler, what type of wave you are going to see? This is the short axis view where we can see the pulmonary valve, which is showing pulmonary regurgitation on color Doppler. And this is the 4-chamber view where we can see a pulmonary regurgitation. So when you put a cursor on this line and press continuous wave Doppler, what you will see, because it is red color, it will be seen above the baseline like this. So it has two peaks, the first peak and the second peak. The first peak is the PA mean pressure. So the PA mean pressure from this diagram, the PA mean pressure is 24. And the second peak is the PA and diastolic pressure plus RA pressure. So when you add RA pressure, consider RA pressure as 5. Then 5 plus 11, so 16 is the PA and diastolic pressure. So systolic pressure can be calculated from measuring the RV pressure in systole, and the diastolic PA pressures can be calculated from by measuring the pulmonary regurgitation jet in diastole, and you can get both the PA mean pressure also as well as PA and diastolic pressure. So the other ways of calculating PA pressure is measuring the gradient across the shunts like PDA and VSD. So PDA jet velocity in systole will give you the systolic difference between the pulmonary artery and the aorta. So if you have an aortic pressure and if you measure the PDA jet, minusing the PDA velocity from the aorta will give you the PA pressure. Similarly, VSD will give you the pressure difference between the right ventricle and the left ventricle. So when you don't have any right ventricular outflow tract obstruction or left ventricular outflow tract obstruction, it will straight away give you the pulmonary pressure estimation. So now we will look at the ductal flow or the PDA flow. It's a very interesting phenomenon that happens in the neonates after birth. If we look at the ductal flow before the birth, that is the fetal life, it is right to left. The PFO is also shunting right to left. That is from pulmonary artery to aorta side. After birth, what will be the flow? The direction and the velocity of the ductal flow can give us useful information on PA pressures. If the shunt is purely right to left, it means that the PA pressures are higher than the aortic pressure. It is still the same what is there in the fetal life. If there is bidirectional shunting across the PDA, it means that the aortic pressure and PA pressures are equal. The bidirectional pattern has a particular characteristic. What is the particular characteristic? In diastole, it will be left to right, and in systole, it will be right to left. Why it is so? In diastole, the diastolic pressure of the pulmonary artery has now fallen, but still the systolic pressure is on the higher side. And the arterial wave from the pulmonary artery, pulmonary valve, will reach much earlier than the aortic systolic wave. So as a result of which there will be right to left shunting across the systole. So this bidirectional shunting is normal during the first 12 hours of life. And later on, it completely changes to left to right when the aortic pressure becomes much higher than the PA pressures. But after 12 hours of life, if this bidirectional flow continues to be bidirectional, then you have to consider persistent pulmonary hypertension of newborn. So now what we are seeing over here is the short axis view, and we can see the red flow. Red flow is left to right, and the blue flow is right to left across the ductus. So this is bidirectional flow, and if you put the continuous wave Doppler on this PDA, you will see this type of image where the red flow is depicted above the baseline and blue flow is depicted below the baseline, which means that during the diastole there is left to right shunt, and during the systole it is right to left, which means this is a normal physiology which happens in all the newborns during the first 12 hours of life. If it persists after the first 12 hours of life, it means that the PA pressures are still high. It is not falling, which should fall. In this particular case, what we can see? We can see continuous red flow. So this continuous red flow means that even in systole as well as in diastole, in both the phases, the PA pressures are less than the aortic pressure. This is total left to right shunting patent ductus arteriosus. This is bidirectional shunting PDA in a patient who is on high frequency ventilation. So when you are doing the echo for a patient who is on high frequency ventilation, you will have similar types of color artifacts. So now what we are seeing over here, the 4-chamber view, and there is a small mid-muscular VSD, and this mid-muscular VSD is shunting bidirectional. So when you have bidirectional shunting mid-muscular VSD, it means that the RV pressure and the LV pressure are equal, or in other words, PA pressure and aortic pressure are equal. So PA pressures are on a higher side. So sometimes it is very difficult. We cannot get the tricuspid regurgitation jet. We don't have a VSD. So what are the other indirect markers from which you will be able to justify that there is presence of pulmonary hypertension? So the indirect markers, first indirect marker, which we have already seen, is right to left shunting across the patent foramen oval. The second indirect marker is D-shaped left ventricle. What we can see over here is there is flattening of the interventricular septum. Normally, the left ventricle in short axis is rounded structure, but because there is high pressure on the right ventricle side, it causes flattening of the interventricular septum, and the right ventricle looks bigger than the left ventricle. So these are an indirect marker which suggests that the PA pressures are likely to be on a higher side. Dilated IVC is an indirect marker. It may suggest RV dysfunction. It may suggest high RV pressure. So how are you going to use this pulmonary artery pressure in clinical practice? So let us understand the hemodynamic physiology. By measuring the tricuspid regurgitation jet, you will be able to come to know that the PA pressures are high. But the high PA pressures can be of two different variety. The two different variety is where the pulmonary vascular resistance is high, and the other variety is PA pressures are high, but the pulmonary vascular resistance is low. So when the pulmonary vascular resistance is more than the systemic vascular resistance, it means that the pulmonary vasculature is completely constricted. It is not allowing the blood to move into the pulmonary circulation. In the other physiology, the pulmonary vascular resistance has already relaxed, but still the PA pressures are on a higher side. So here the pulmonary blood flow is increased. You will see significant amount of blood flowing into the pulmonary artery. It can be because of PDA, but in this particular case, the pulmonary blood flow is very, very less what we see in the fetal life. So when you see high PVR physiology type of pulmonary hypertension, it is called obstructive pulmonary hypertension. And when you see low PVR physiology type of pulmonary hypertension, it is known as hyperkinetic pulmonary hypertension. So what is the idea? When we have a patient with high velocity of tricuspid regurgitation jet, you don't have to jump on management of PPHN. What should be done? You have to quantify whether this pulmonary hypertension is because of obstructive PAH or is because of hyperkinetic PAH. The management differs if there is obstructive PAH or if there is a hyperkinetic PAH. So we'll come to a patient where you have a term child, there was no cry, and RA-RV are dilated, PDA is right to left, PFO is right to left, RV dysfunction. So what are we dealing with? We are dealing with pulmonary hypertension. And because the PDA is right to left and PFO is right to left, which means that pulmonary vascular resistance is higher than the systemic vascular resistance. That is why the PDA is right to left. So we are dealing with obstructive type of pulmonary arterial hypertension when PDA is shunting right to left. So when PDA is shunting right to left, we are dealing with obstructive hypertension. We need to relax the pulmonary vasculature. So we need to give pulmonary vasodilator. The treatment of choice for obstructive PAH is pulmonary vasodilator. So we need to relax the vessel. So the patient was kept on high frequency ventilation, nitric oxide, and milrinone. Milrinone is also a pulmonary vasodilator. Nitric oxide is an inhalation pulmonary vasodilator. It is not freely available in majority of the centers, but it is wonderful drug and acts within only few minutes. So what we are seeing over here is the PFO shunting right to left, and here this is the image. Because the patient is already on nitric oxide, we see this type of artifacts, and the tricuspid regurgitation jet we are seeing over here, this coming around 35. So 35 is also high PA pressure, and but the PFO is right to left, which means that the systemic pressures are also on a lower side. The child is in shock. So after giving this medication, what happened? The child showed clinical improvement. The child could be weaned from the ventilation and inotropes. So what was the echo findings later on? The PFO, which was shunting right to left, have started shunting left to right. And the PDA, which was shunting bidirectional or right to left, has started shunting left to right. So these are the signs of clinical signs or echocardiographic signs of improvement after giving treatment. So it helps us whether we are in the right direction of treatment or not. So this is the Doppler of a bidirectional shunting PDA and left-right shunting PDA. So when you have this type of Doppler, it means that it is obstructive PAH. And when you have completely left to right, when you see a continuous flow, it means it is hyperkinetic PAH. So it is very, very important to define the type of pulmonary hypertension. In case of pulmonary hyperkinetic PAH, if you give nitric oxide and sildenafil, the lungs will get flooded. So this was the X-ray picture showing significant improvement after the treatment for obstructive pulmonary hypertension. So we have a preterm post-surfactant phase. Surfactant was already given to the baby. The child has improvement of the lung compliance and was weaned from the ventilator on the 3rd day. But on 5th day, the child again had tachycardia and respiratory distress. So what was the likely cause? Majority of the neonatologists will think that the PDA has got manifested. So the echo was done and echo showed PDA. So because now the PDA is seen, what is to be done? Do we need to close this PDA? No, wait. We need to see whether the PDA is completely left to right, right to left, or bidirectional. So the Doppler data showed that it is a bidirectional shunting PDA, which means that there is some element, still some element of obstructive PAH. This is not the hyperkinetic PAH. We cannot close this PDA. If you close this obstructive PAH PDA, then the right ventricle will fail. So the oxygenation was continued and the efforts were made to decrease the pulmonary hypertension with the help of pulmonary dilator. But if you consider the same scenario and this type of PDA, then it is hyperkinetic PDA, hyperkinetic pulmonary hypertension, and these PDA can be closed with medications. So the bidirectional shunting across the PDA goes more in favor of non-regression of PVR rather than hemodynamically significant PDA. So we have another child where we have already treated the child for PDA is a 900 gram, and on 10 they develop respiratory distress. So what could be the possible cause? We can see a 4-chamber view showing all chambers are equal, but there is tricuspid regurgitation velocity of 39. So 39 velocity means the systolic pressure is high. So when you have systolic pressure high, you add 4 to the tricuspid regurgitation jet, 5 to the tricuspid, it will be around 40. So 40 of systolic pressure is a high pressure. So whether it's a pulmonary hypertension secondary to obstructive PAH or a hyperkinetic PAH, what we saw that the PDA is already closed. So the pulmonary hypertension is neither due to high pulmonary vascular resistance and nor due to the hyperkinetic PDA. What we found out that it was the collapsed lung, it was the parenchymal disorder which was responsible for pulmonary hypertension. So when you have lung conditions like meconium aspiration syndrome or collapsed lung or various other congenital or acquired pneumonia in a neonate, these conditions can also lead to pulmonary hypertension. Not always you can have a PPHN or a PDA which is responsible for pulmonary hypertension. So echo showed high PA pressures, which was because of left lung collapse. So now we have fourth case where we have 36 speaker for fetal distress and was immediately taken for LSCS. After the LSCS, the child did not cry and later on developed secondary apnea. Patient was intubated. What we saw that there is whiteout of both the lungs. An echo showed RARV dilated, PF4 right to left, and ventricular dysfunction. So when you have RARV dilated with PF4 right to left, what is the type of pulmonary hypertension? The pulmonary hypertension is obstructive pulmonary hypertension, that is persistent fetal circulation type. It is not a hyperkinetic PAH. It is a obstructive PAH. So when you have obstructive PAH, what is the line of mechanism? Pulmonary vasodilators. So what we can see over here, we could not get the tricuspid regurgitation jet, but what we can see, the LV is D-shaped. LV is D-shaped and the right atrium is, right ventricle is much bigger than the left ventricle. These are the indirect markers which suggest that the PA pressures are high and the PDA is already closed. So how are we going to get the gradient across the PDA and quantify the type of PA pressure? So in this particular case, we had PDA closed immediately at birth, which means that PDA was not closed after birth, but it was closed before birth. And that was the main culprit responsible for fetal distress. What we call it as a premature closure of ductus. The NSAIDs like ibuprofen are very frequently taken in the peripheries for abdominal pain in the near term mother. So what will happen if the NSAIDs like ibuprofen, Combutem, anything is taken, it will cause closure of the PDA because it is a cyclooxygenase inhibitor. It will close the PDA even before the child is out. And once the PDA is closed, what we have learned that the PDA sends whole blood, the blood to whole of the body. Only 10% blood goes into the lungs. So if you close 90% of the outflow tract, then what will happen? The whole blood will get flooded into the lungs. And because of that, you will have whiteout of the chest X-ray. So when you have whiteout of chest X-ray and PDA closed at birth, it is more likely premature closure of ductus. So we have another kid who is 5-day-old having respiratory distress, cardiomegaly on X-ray, severe metabolic acidosis, and you have obstructive PAH, PF4 right to left, RARV dilated. So what the echo is done, you can see the LV is D-shaped, the right ventricle is dilated. So obviously there is pulmonary hypertension. There is no PDA in this particular case, but if you look at the size of pulmonary artery and the aorta, the pulmonary artery is much bigger than the aorta, which means that the PA pressures are high. The interesting finding that we saw, the transverse arch is showing flow reversal. The blood is going into the right subclavian artery. in the upward fashion. Normally the blood comes like this and then goes this, but during the diastole, the blood is moving in the opposite direction. What does it suggest? It is called diastolic runoff. It is suggestive of something there above where the pressure is less and it is causing a still phenomenon during the diastole and the blood is moving in this direction. The diastolic vascular resistance is more over here and the diastolic vascular resistance less over here. The blood is bound to move in this direction during the diastole, and hence we are seeing this to and fro movement in the transverse arch. What we came to know that there was a dilated IVC and there is some continuous flow inside the dilated IVC. So actually there was a communication between the right subclavian artery and the superior vena cava, what we call it as a systemic arteriovenous fistula. This systemic arteriovenous fistula was responsible for PPHN type of physiology. So this child was operated surgically, and after this thing was operated, the PA pressures came down and the child could survive. So the PPHN physiology is a very common diagnosis that we make in a sick child, but there are two cardiac lesions which could be missed considering it as PPHN physiology. And this portion I also taken in the previous lecture of shock, where we cannot miss this PAPVC and coarctation if we are suspecting a PPHN physiology. So when we are suspecting a pulmonary hypertension in a newborn who is sick, always ask your cardiologist to rule out PAPVC and coarctation of aorta. So what are the clue features which will help us diagnose that PAPVC or coarctation is there? So when you have a 3 vessel in a subcostal view, then one should strongly suspect PAPVC. When there is obligatory right to left shunting across PFO or ASD, one should always suspect TAPVC. And when you see a common chamber behind left atrium, one should suspect TAPVC. So what are we seeing over here is we can see that there are 2 vessels, the aorta and the IVC. So in the subcostal view, we will see only 2 vessels normally. But if we see 3 vessels, IVC, additional vessel, and aorta, when 3 vessels are seen, one should suspect infracardiac TAPVC. This is a subcostal 4-chamber view where we can see a common chamber behind the left atrium and there is obligatory right to left shunting. What is obligatory right to left shunting? Irrespective of systole or diastole, if you have right to left shunting, it is called obligatory right to left shunting, and it has nothing to do with the respiratory variation also. But in patients with severe PPHN and when you have right to left shunting across PPHN, there will be some episode where you will have a transient left to right shunt also. So when you don't have that transient left to right shunt, you have continuous right to left shunt. It is known as obligatory shunting, and it is not affected by respiration as well as by the type of cardiac cycle. So this is a common chamber which is opening into the coronary sinus. So this is also a cardiac type of TAPVC. So what are the various clues to coarctation of aorta? When you have ventricular dysfunction, bicuspid aortic valve, and bidirectional shunting PDA, despite being small. So there is 4-chamber view where we can see that the myocardium is hardly contracting. The short axis view where the myocardium is hardly contracting. So when you see a ventricular dysfunction, always rule out coarctation in a newborn. So this is a PDA view where we can see that the PDA is now so small, but still it is bidirectional. Normally, when the pulmonary vascular resistance falls, the PDA closes. That is the normal physiology. But in this case, we are seeing that the PDA is already closing down, but still it is bidirectional, which means that there is something abnormal on the pulmonary venous side, which is not allowing the PA pressures to fall again. It is now again rising PA pressures, which will make the PDA bidirectional. This is the bicuspid aortic valve where we can see where we can see 2 shunts, 2 cusps, 2 leaflets opening, and there is 1 commissural fissure. As a result, actually, it's a functionally tricuspid valve where 1 cusp is fused, and and hence it functioning as a bicuspid valve. So to summarize, pulmonary hypertension is not a disease. It is a sequel to a disease, and different etiology can have different hemodynamic physiology. Always try to define pulmonary hypertension in terms of high PVR or low PVR, like obstructive PPHN or a hyperkinetic PAH, because the management will be different in both the cases. In case of obstructive PAH, your primary plan is to give pulmonary dilator, and in case of hyperkinetic PAH, the plan is to treat the physiology, either pneumonia or PDA. Always rule out primary hypertension before planning indomethacin therapy in a symptomatic preterm child of PDA. Rule out coarctation and TAPVC before making the diagnosis of PPHN. PPHN is a diagnosis of explosion, should be labeled when no other cause is found. You might have a rare cause of systemic AV fistula in any part of the body, or more commonly what we see, vein of Galen in the brain. These are the rare causes which can cause pulmonary hypertension in newborn and should be considered sorry, when no cause is found. Thank you so much for listening to me. I wish you everyone happy Diwali and New Year in advance. Welcoming the questions.
Thank you very much, sir, for taking us through very detailed presentation. But you explained it very lucidly. You made this topic very informative, and we have one question from Dr. Vijaya Lakshmi. How to grade PAH in neonates based on RVSP?
Okay. See, basically, we have the same formula of if the we compare it with the aortic pressure. Anything which is more than 2/3 of the aortic pressure is a severe PAH. 1/3 to 2/3 is a moderate PAH. Less than 1/3 is mild PAH. That is how we calculate, because depending upon the level of prematurity, the normal aortic pressure could be 40/20 in a very early preterm child. And hence, if you measure a tricuspid jet of 25, that 25 will also be a severe PAH in a 26-weeker child or a 28-weeker child. So what we do is we try to quantify in terms of the aortic pressure. We consider it as severe if the PA pressures are more than 2/3 of the aortic pressure.
Okay. There is no questions in chat box, sir.
Okay.
Yeah.
If anybody wants to ask the question directly, they can raise the hand. We can
Unmute you, yes, sir.
unmute them.
I think topic is well understood by everyone. So no questions so far.
Or it could be either way around. Nobody understood anything. Okay, then I think
We should end this section.
we have covered the topic well. And like if somebody is having query, they can contact me personally. Thank you so much.
Thank you, sir.
Yeah, I think we can leave the meeting.